Here, continue to document as you would other peripheral IV insertions. In the ER, we have a specific spot that says, was ultrasound guided technique used, yes or no? And we click yes if we use it. I don't know if the floor ICU, they have that?
Yeah.
Okay, good.
They're telling
So
me.
just click yes if you use this technique. And that way other people know that they have a longer catheter in there when they go to take it out. DCing it's the same as DCing any other IV catheter. Just hold a little pressure there and put a gauze, 20 gauze on it. Document if any complications occurred while attempting to insert a catheter. It should always have blood return, being that they're inserted in larger veins. So it's not like a 24 gauge. You should always be able to aspirate blood. You may have to flush it once and then aspirate, but flushing these catheters doesn't really determine proper placement. Because up here you have a lot of sub-Q tissue. You can flush 10 syringes in it and you won't be able to feel if it's infiltrated or not. So always make sure you have blood return before you use it. And then you can also take the ultrasound probe itself, put it up above the catheter while you're flushing and visualize the flush going through the vein. So that's another way to confirm placement too. That's how I usually do it, is look at with ultrasound and flush it and make sure I can see it flushing through the catheter itself, or the vein itself. But blood return is the easy way to do, a quick way if you do something quick. So complications here, arterial punctures. Beginners are very concerned about this. If proper technique is followed, studies show risk is actually very, very low. It's like 0.03% arterial punctures on most of these studies I reviewed. Just because you have a lot of techniques to determine artery versus vein. The only real time this happens if you lose sight of your tip and you just poking in there and you may hit artery. So you don't want to do that. Just make sure you visualize your catheter at all times. And nerve irritation is the next one. This can happen because nerves are sometimes, like I say, hard to visualize where they are. If you stay away from that brachial complex in the upper arm, you should be okay. But if you have to go that way, you may get a nerve. Patient may say lightning bolts are jolting down their arm every time you try to move that catheter. That means you're touching the nerve or poking the nerve. You want to pull back and try to go at a different angle or a different site altogether, or just move your site up or down the arm, depending. The IV catheter should be discontinued immediately if you are hitting a nerve, and then the new insertion site addressed. So that their hand could be twitching like this if you're hitting the nerve. They may not tell you it's hurting, but it's probably hurting them if their hand starts twitching. And then infiltration, most causes of this are veins being too deep prior to IV attempt. 1.5 centimeters or less. Can't stress that enough. Because you can reach deeper ones. It just, once the patient moves his arm, then it'll infiltrate. And then infection, that's normal infection rate. Make sure you keep your ultrasound probe clean and the site clean. Use sterile jelly. Don't poke through the jelly. That's about it for that one. Keep everything clean. Potential for DVT, that's another one. The study was showing they're almost the same risk as normal peripheral IV for DVT, so very low. And then very low risk for any serious adverse effects from occurring. Some common pitfalls here. Accessing the outer layer of the vein. This is what we were saying about getting your bullseye initially and then not following it in the vein and then trying to thread it. So that'll give you resistance when you try to thread it if you don't have your cannula through the vein too. Unable to visualize the needle tip. So this is very common. You can kind of wiggle your catheter back and forth while you're visualizing with the probe. So you're holding this still and you're doing this, and you'll see on the screen this thing is jumping back and forth. And I keep doing this until it disappears, and then I bring it back a little bit. So that's where I know it's right on the tip and I'm not looking at the half of the needle. jiggling around. I'll keep going until it disappears, and then I bring it back to where I first see it. And that way you know you're right on the tip of the needle. It gets easier with each consecutive attempt. Speaking of that, they say you're not really going to know if you can do it or not if you don't try 10 times. So at least try 10 attempts before you say, oh, I give up on this, I can't do it. Because some folks try twice and say, oh, I'm done, I can't do it, it's not for me. So just make sure you keep trying. It's like we're starting all over again with IVs. So just think about when you first started IVs. Weren't too good at it, so you may have been good at it the first time, but that's good. The next pitfall is you hub the cannula, but it still hadn't reached the vein. Either your vein is too deep, should be 3 dots or higher. Your angle of insertion is too shallow. You know, you got the right depth on your vein, but you're trying to go too shallow to get to it. So come back out to the skin and then steeper angle and go back into it. And then here's what I was saying earlier. From experienced patients say the only part that's really painful is the initial insertion through the skin. Much more nerve endings in the skin than it is in the soft tissue below. So once you're going through that soft tissue, unless you hit a nerve, it shouldn't hurt that much. Patients might be screaming just because they don't like IVs, but usually it doesn't hurt as bad. You can always use the spray or whatever you want to use for the initial insertion if you feel bad for the patient or something. I use it on pediatrics, so
we don't have
the spray is good.
Yeah, we don't know what you're referring to.
We don't have spray. Huh?
Yeah,
I know what you're talking
Amyloid
about, but we don't
cream
have that.
if you have time.
We don't do that.
But for the pediatric patients, it's good.
We'll just push a little Versed first.
Don't give any morphine, it's not moderate sedation, so we're good.
As long as it's not over 5 milligrams, 2 a person. Alright, in summary, be patient. This technique has a strong learning curve. Just think about when you first started IV insertions for the first time. The more you do, the better you become, and then at least 10 times before giving up on the technique. Keep your eyes on the screen during the insertion. Don't look back at the site every 3 seconds trying to figure out what you're doing. Find it on the screen while you're looking. It kind of gets easier as you do it. Stick at a steeper angle. Stabilize the probe with your pinky finger, medial aspect of your hand. It'll help you stabilize the probe on the skin. Avoid sticking too steep of an angle. You may kink the probe once threading it. Make sure the vein's located at 1.5 or above on sound screen. So some outcomes here from the studies. Meta-analysis, 8 different studies, over 1,600 patients, resulted in a success rate of 85%. And that's just starting out, so that's really good. And the same analysis, this is all difficult IV access patients, not normal patients. The same analysis showed an average success rate 2.49 insertions per patient. So their initial study showed that new nurses trained at average of 2.5 IVs per patient, 2 attempts per patient. So it may take 2 attempts or 3 attempts initially to get it down, to get you one in, but just keep trying, you'll get it in. Another study resulted in a reduction of the total number of insertions attempted and the increase in patient satisfaction, and that's the most important part of this whole thing is the patient satisfaction in every study went way up after initiating this program. And then the use of the Ultrasound Guided Access program reduced overall costs in the unit where it was implemented, given that it had adequate success. And so the log, the ultrasound log and stuff, that's going to help hopefully improve our success rate and get more nurses competent. Another study showed only 40% of nurses in the classes were gained competency. So what do we have here? So 3 out of the 7 of y'all gained competency, then that's a good success rate, depending on the research, judging by the research. So, and I would think we have probably 8 or 9 out of 80 people trained in the ER that could actually do it competently. So, and that helps us out tremendously. If you have one person on the unit that can do it, you only have so many difficult accesses at a time.
We probably have a higher rate up here.
I was gonna say all of us are gonna be able to. That
Yeah.
number is not right. All of us.
I think we'll
Most
just
of
have-
these studies are from ERs, because that's where they usually implement it, but
Yeah,
some of them for ICU, but,
we typically, most of our patients really, really sick, so.
yeah, I mean, and they're unconscious most of the time, so
Yeah.
it can be easy to start on an unconscious person versus somebody yelling at you and jumping around on the bed.
No, we just get a little mercy.
Yeah. That's just references of all those studies, and some images there. So that's it. Any big questions right now as far as,
Gotta see it.
you gotta see it? Yeah, I know. So we'll get the ultrasound machine in a second, if y'all wanna take a little break, bathroom break.
Only one question, this is still with tourniquet?
Everything, yeah, everything's the same as a normal IV, except for the prep.
And how long is that needle again?
1.88, so there'll be a box of them.
So you don't know, but you're only like a hair more than the depth you could possibly go.
Yeah, it's 1 point, this is inches, those are centimeters. So 1.5 centimeters versus 1.88 inches.
Alright,
So
yeah.
it's a lot longer as far as that goes. Might need a bathroom break.
Yeah, let's see.
Alright, 10 minutes.
How many are we saying we have to have?
3.
Is it 3?
Yeah.
That's what I thought, but I wasn't sure.
And so
Sure.
far the intensivists, like you say, hey,
Somebody
we're
email.
doing this, they've been
Yeah.
like,
Somebody
okay,
email.
just get your stuff together, and they
Okay.
come and watch you.
Cool.
Can you send it to me?
I've only done
Is he
2.
back
Have you done it? I haven't even
We're gonna make him
attempted it
look
yet.
at Just keep them.
The intensivist has to be the one.
So,
to
Or
in-
like Chelsea and
Yeah,
We'll come back and look at
it'd
it.
be like Chelsea
See what
or
everybody's-
or
I'm gonna tell them to, put
Tiffany
comments
or
somewhere on the back or something.
Fairport.
if they have difficult-
surgeons or
The
whoever's
residents.
competent,
but did the residents back out on us?
totally backed out.
Totally backed
I
out,
got
okay,
this
then we'll see.
email from their director
That's fine.
saying, yeah, you
Get a
can
log
hold
on
a
first.
class
Okay.
for them
But
exclusively.
as far as the competency, they have.
And then they can supervise,
three
to which I
attempts.
said,
And we have an
no.
ER, an actual page,
So,
Okay.
and you just keep up
Oh,
with
so
that
we
as far
need
as
to have
competency goes.
So you have competency.
For the first
the
couple
first
of months.
three.
Is that just free to go stick?
What's
Yeah.
that? Denise said she's gonna send it to
So
me.
like another nurse that's competent.
yeah.
Ventilated patient?
One, I was about to say, once we have
I don't
consent, we
understand,
then
that's
able
ultrasound
Check
look.
people
Check
off.
people
Ma'am, I know
After
you
I
can't
talked
hear
to
me.
Candy, she said, yeah.
Yeah, I would think,
I mean, I would think
yeah,
So,
yeah, okay.
Because
Cause then you can, we would consider ourselves essentially super users for it too, so.
yeah.
If you do clinical ladder stuff, you can totally get some points for that.
Yeah. And,
I'm all about
Yeah,
some
you get some
clinical
points
ladder.
if you're checking off. folks.
Yeah.
I got it on mine.
Yeah, I'm all about some clinical ladder, y'all.
I'm glad you can
Telling
help
y'all.
me.
How to do this.
if you can snag an NP instead of one of the doctors, cause they're all old and really just set in their ways.
Yeah.
They'll take like Tiffany Quentin took the time to like really help me out, explain it,
Yeah,
like
yeah.
give me some good tips Dr. Martinez didn't provide.
Dr. Martinez.
It was just like, so you stand 6 feet back, like a
And then,
javelin, and it lands in the
Dr.
vein.
Martinez was
This
kind
javelin
of
is
like,
you
and
just,
good luck, cause they pop
you
out
just-
all the time,
you
you
just
know, I
take
feel
it
like
and
he
you
was
just-
kind of
you
negative
just-
about it.
when I
And then you
talked to
just,
him
and then that's it.
I didn't know what I was getting.
Fucking see him doing
When I
that,
talked to
though.
him at first, he was like, yeah, I'd love to do that, we need
And
education.
there you go. It's easy peasy. Of course, now this tissue is not necessarily
It's like, yeah, but I don't know why we're
optimal
doing this.
tissue.
But no, the two I've gotten
But it
work really
does.
well, and